Okay, our third speaker of the afternoon is from Canada, and Elaine's going to speak to us on the title of Would You Do It Again? A patient perspective regarding their decision for PEG in ALS. Elaine.
Well, in the words of Monty Python, and now for something completely different. I just thought I'd start out by giving you a bit of background information on who we are. The Ottawa Hospital Rehabilitation Centre is a physical rehab centre. Our patients come from the Greater Ottawa area as well as Eastern Ontario and Northern Ontario. The ALS clinic is a multidisciplinary team that includes a physiatrist, a nurse, our nursing clinic coordinator, Sue, who's one of the co-authors of this paper, myself, the dietitian, two speech and language pathologists, one who does our speech and swallowing, and Margot, our other one, who's the other co-author, who now works with the AAC. We also have a physiotherapist, two occupational therapists, one who works with Margot on AAC, social worker and chaplain, as well as respirologist and respiratory therapist. So we're a pretty complete team. Our patients are referred by a neurologist. We follow about 120 patients yearly. They're seen at our weekly clinic about every 3 to 4 months, and we can refer out to community providers. We also liaise with the local chapter of the ALS Society, who are very involved with their patients. In Ottawa, enteral feeding is done by PEG. At this time, about 34% of our patients have a PEG. This fluctuates. When we started our study, it was about 37%. So when it comes to PEG and ALS, what do we know? Well, we know that the main indicators are dysphagia, inadequate intake, and decreased pulmonary function. The literature says that 16 to 21% will develop malnutrition, even those without dysphagia, and that 70 to 80% will develop dysphagia that requires modification in food texture or fluid consistency. According to the AAN practice parameters, PEG is probably effective in stabilizing body weight and body mass index, and it's probably effective in prolonging survival, but by how long has not really been quantified. But PEG does not stop the progression of the disease. There are risks associated with the procedure, which, although relatively uncommon, can be serious, especially for those who have a compromised nutritional status or pulmonary function. But PEG has become the intervention of choice, and many of our patients choose to get it. Looking at PEG and ALS and quality of life, there are studies on quality of life and enteral feeding, but they've used a mixed cohort and none have been ALS specific. There is a validated quality of life ALS tool. However, it really addresses if a patient has had problems eating, not the value of eating in a person's life. Reviewing the literature for studies on quality of life, PEG, and ALS, this area really hasn't been explored. There was a study by Brotherton who asked the question, but unfortunately the responses were not reported or discussed, nor any conclusions made. So attention has been given to the decision-making process, but what about after a person gets a PEG? There was a poster in the 2000 International Symposium that reported the results of a study of 9 patients. They indicated that generally they were glad that they had the PEG. Now, perhaps at your clinic you've been addressing this aspect, but there doesn't seem to be much in the literature. Our clinical impression is that patients are satisfied with their decision, but we felt it was an area worth exploring by asking the question, would you do it again? With a lack of literature in the area, this was aimed at being an exploratory study. So rather than having a long multi-item survey, we decided to keep it simple at this stage, asking them if they had to make that choice again, would capture what we want to know. So for this study, we recorded the answers to 3 questions that myself, the dietitian, and the SLP and the nurse usually ask in the course of their normal clinical care. The first is, are you an eat-to-live person or an eat-to-live? Eat-to-live or live-to-eat? It's a question I ask at the initial assessment, and it's actually a question I've asked for quite a number of years. It came from a study that myself and the SLP at the time presented actually at the 1999 International Symposium that looked at our patients who choose not to have a PEG. So basically, eat to live, as you might think, is food is not that important. You eat because you know you need to get your nutrition, but it's not that important a part in your life. Versus live to eat, you love food, you love to eat. The question really reflects the importance of eating and food in a person's life. And I have found, just anecdotally, that it's a fair indicator of acceptance or rejection of enteral nutrition in the first place. Some live to eat people will continue to eat even when the risk is high. The second question is, how was the PEG procedure and did you have any complications? This is asked at the first clinic visit after the procedure. I like to find out how it went, but it also reflects the experience of the procedure, which may influence their subsequent attitude to having the PEG. A person who was very positive about getting a PEG may feel less so if their experience was not good or if they had complications post-procedure. And finally, would you do it again? This is asked when the patient actually starts using the PEG for nutrition or hydration. There's often a period of time between the procedure and when they start using it. And we felt that when they actually start using it, does it become real and they can consider their satisfaction with their decision? It's a difficult question to ask. It requires rapport with the patient, timing, and some sensitivity. So it doesn't sound like we're questioning their decision or passing judgment on their decision. But it did make people think about their decision and consider their response. Along with the yes or no, would they do it again or not, we also recorded comments that they made. We also collected other data such as the site of onset and the indicators to determine if there was a correlation between would they do it again and the variable and their answer. So that we had a study group of 44 patients. We have complete data for all the answers to all three questions for 28. This number is a little different from from the abstract because we actually continued to collect data until about a month ago. 16 patients with PEG but incomplete data were not included. They were incomplete for a variety of reasons. Some were deceased. Some did not return to clinic because of declining status, or they lived a long distance from clinic. They'd moved to another city. Others were transferred to complex continuing care, at which point we no longer see them. Some had PEG placed, but hadn't started using it by the time we did finished our study. There were 17 women and 11 men. 12 were limb onset, 16 were bulbar, and most had 2 indicators. Some even had all 3. Of the 28 in the study group, 25 said yes, they would do it again. 3 said no, they would not do it again. In response to the question, are you an eat to live or a live to eat person, it was divided half and half. 14 were eat to live and 14 were live to eat. However, when divided into the yes or no groups, all of the no's, no, they would not do it again, were live to eat. Primarily post-procedure pain was the most frequent complication, ranging from mild to severe. Next was infection, and one had post-procedure aspiration that required suction. Complications did not appear to have an influence on whether the patients would do it again, even with complications such as severe pain, and the person who had aspiration requiring suction said that they would all do it again. And site of onset and indicators for PEG did not appear to influence whether or not they would do it again. What we found really interesting were the comments. The comments from the no group were not surprising in their negativity. It was inconvenient. They'd never really healed. They lost weight and stopped using it. When we looked at the comments from the yes group, they would do it again, it was clear that they fell into 2 categories. One were very positive. They were glad to have the PEG for medications. They would not have a good quality of life. I love it. A lot more positive than I anticipated. Happy I got it. Saved my life. I miss food, but it has helped me a lot so I don't have to struggle. Well worth it, without a doubt. And our favorite was the last one. It has allowed me to play golf. And in fact, this man continued to play golf for 2 more years after he had his PEG. What was really compelling was that half of the comments from the yes, they would do it again were negative, and some were quite serious. I miss eating. The alternative is I would waste away and shorten my lifetime. Did not have a choice. Wonder what people did before PEG. Without PEG, what were the options? Starve or choke. It was not a choice. I miss eating. And adjustment with body image. What's interesting is that 2 people said that they didn't have a choice. We actually do present all the pros and cons, the risks and benefits in a pretty unbiased manner, and we make it clear that it is their decision, and whatever they choose, we will support it. When we grouped the no, they would not do it again, with the yes, they would do it again, but had negative comments, the picture changes. In that group of 9 patients, 8 were live to eat. Food and eating is very important to these patients. In the yes group with positive comments, they were mostly eat to live. Food may not be as important to them, and making PEG more acceptable to them. In conclusion, yes, the vast majority of patients would do it again, which confirms our clinical impression that most people are satisfied with their decision. What really stood out was when looking at the no and the yes, they would do it again with negative comments, almost 90% were live to eat. And that most positive comments, 71%, came from the eat to live group. We know that all patients need continuing support after PEG. The challenge for the clinic team is to develop strategies for patients with PEG and their families to cope with their decision and make living with it a positive experience. Food is very important as a source of pleasure as well as nutrition. We see patients grieving at the end of eating when they transition to total enteral feeding by PEG. We wonder if this actually should be added as an item in the ALS Quality of Life Survey. But by simply asking the patient if they are a live-to-eat person or an eat-to-live person may give us an important clue as to those who may have less satisfaction in their decision and may need some additional support. Of course, we have a big thank you to our patients for giving us insight into their experiences. This is all of our contact information, and we actually will be presenting this as a poster at the International Symposium.
Thank you, Elaine. Okay, question time. Do I have any questions for Elaine? Okay, one up the back.
Wonderful presentation. Rebecca Axline. I'm a social worker in Houston at the Methodist MDA ALS Clinic. There weren't any specific questions, but did you address in some of those eat to live, live to eat, the socialization aspect of eating? Because that seems to be very important to many of our folks.
I think peripherally I get an impression of it. It works both ways. Some people find that having a PEG and being able to socialize is very liberating. They don't have to worry about the problems that they have eating. Other people find that it really compounds how much they miss eating, and they actually start salivating because of the smell of food and watching everybody else eat, and that's a little bit distressing to them. So, but it wasn't addressed specifically in this study.
We've just had some comments, for example, in their religious activities, not being able to take communion, not being able to go out with their friends, those kind of social aspects.
Absolutely, and we actually once had a Catholic priest who it was very difficult when he actually couldn't take the host anymore.
Thank you. Anywhere else? Yeah, okay.
So one of the issues that we come up with a lot is this issue of my lung function is declining so quickly that I need to make the choice about gastrostomy prior to the time that I really can't functionally eat.
Absolutely.
Can you discuss a little bit about how the respirology choices affect your patients, and when that's the driving force, what happens to satisfaction?
Interestingly enough, I don't think we had anyone whose sole criteria for getting it was FVC. It was looking at the whole combination. You know, it wasn't that their FVC was getting so low that they actually had to make a decision right away. It's when you start seeing it go down a little bit and they're starting to have a little bit of problems with dysphagia and they're starting to lose a little bit of weight, and you put those all together and you're starting to look at high risk. So we really try and be as proactive. That's why there's such a gap for the most part, between when they actually get a PEG, because they're doing it proactively, and when they actually start using it.
Thanks.
Anywhere else? Yep. Question down the front. So we'll take this one first and then the standing mic.
Well, it's a question and a comment, I guess. I'm a dietitian in Wisconsin. I think a lot of the negative comments or the no's you were getting weren't really necessarily negative about the PEG itself, but negative that they can no longer safely eat. Would you say that that's accurate, or an inaccurate impression that I got?
I think most of them were. It was their attitude to PEG that they felt that they had to get a PEG, that they didn't have a choice about it, and so. I'm not sure. I'm not sure about that.
Okay, and in the middle.
Richard Sloan, palliative care physician from the UK. Just coming back to those patients say, well, I don't have a choice, do I? It's either a PEG or I starve to death. How do you explain to them what will happen?
Yeah, that's a really tricky one when they say, well, what if I don't get a PEG? Again, it requires a lot of sensitivity, and my usual answer is that eating will become increasingly more difficult and more unsafe, and that you'll be able to not meet your nutritional requirements and your hydration requirements, and maybe even get your medication. I must admit, I just kind of leave it at that. But I think the nurse has a lot more discussion with the patient around that, and a respirologist as well.
No, I think that's good. I was looking in the literature in the UK recently just to see what are people told in written, published literature about what the alternatives are. I mean, I explain it to patients in saying that they'll get weaker, they'll get more sleepier. It's not the horrendous thing that people imagine, that you'd be less aware of the lack of hydration and nutrition. But it's easy to say that. Another thing to believe it.
And we have about 10 to 15% of patients who choose not to get a PEG, and they're well aware of, what the issues are going to be. We say, we'll support your decision. We'll try and come up with a plan B or a plan C or however many plans it takes. But eventually it will get to the point where none of those plans will work. And that is difficult too. But some of them, as I said, they will continue to eat no matter what the risk.
Okay, thank you. So join with me, audience, please, in thanking Elaine for that presentation.